All right, we're going to start now, guys. Hello, I am Eileen Thompson, Program Director of the PA Medical Home Initiative. I would like to welcome you and all to the Treatment Across Lifespan for Persons with Fetal Alcohol Spectrum Disorders webinar. This webinar is provided through a collaboration between the PA Medical Home Initiative, a program of the Pennsylvania chapter of the American Academy of Pediatrics, and funded by the PA Department of Health. This webinar aims to identify potential referrals, secondary conditions, risk factors, and care planning for individuals with FASDs. Describe developmental and functional concerns for individuals with FASDs and their families. Explain various treatment approaches for FASDs, and explain support services and resources for families and providers. This webinar is recorded. The recording will be available on both the PA Medical Home Initiative and will be posted on the University of Pittsburgh Internet-Based Studies and Education and Research website. For CME purposes, please be advised that both Dan Dubowski and Dr. Turchi have no disclosures. Please note that the information presented in this webinar is educational in nature and does not necessarily represent the views or policies of the PA chapter of the American Academy of Pediatrics or the funders. Please allow me to introduce Dan Dubowski, Master's of Social Work. Dan has worked for over 40 years in the field of behavioral health. He has worked as a child care worker in residential treatment and as a therapist in residential treatment, inpatient, outpatient, and community settings. Dan has been involved in the field of fetal alcohol spectrum disorders for over 20 years. He has presented regionally, nationally, and internationally on FASD, focusing on interventions and prevention for children, adolescents, and adults. For this work, his son Bill, who was diagnosed with fetal alcohol syndrome at age 19, has been his mentor and best teacher. In addition to FASD, Dan has developed curricula for provided training and technical assistance for families and professionals working in mental health, developmental disabilities, education, justice, vocational services, and substance abuse treatment on loss and grieving, psychopharmacology, child and adolescent development, violence in youth, anger management, team building, stress and burnout, transition, and lifespan disorders such as attention deficit hyperactivity disorder, mood disorders, and schizophrenia. Dan has also co-facilitated a group for non-offending caregivers of children who have been sexually abused. For 14 years, Dan was the FASD specialist for the Substance Abuse and Mental Health Services Administration, FASD Center for Excellence in the U.S. He currently works as a consultant, providing training and technical assistance to agencies, communities, states, grant programs, and provinces. Dan has a keen interest in improving outcomes for families, individuals, and the providers and services that support them. I would also like to introduce Dr. Renee Turchi. After completing undergraduate work at Cornell University and medical school at Medical College of Pennsylvania, Dr. Turchi completed her residency and chief residency at St. Christopher's Hospital for Children in Philadelphia. Subsequently, she attended the Robert Wood Johnson Clinical Scholars Program at Johns Hopkins University, where she received her master's in public health. Her research and clinical work focus on children and youth with special health care needs. Dr. Turchi is faculty and an associate professor at Drexel University School of Public Health and Drexel University College of Medicine. In addition, she is the medical director of the Pennsylvania Medical Home Program and Transition Program, a statewide quality improvement program for pediatric practices across Pennsylvania and funded by the Pennsylvania Department of Health. Dr. Turchi is medical director of Special Needs Program and section chief General Pediatrics at St. Christopher's Hospital for Children in Philadelphia, PA. Her research and clinical work around care coordination and children and youth with special health care needs have been presented and published in multiple national forums. Most recently, Dr. Turchi was nominated as the Pennsylvania Pediatrician of the Year by her peers. We are delighted to have Dan Dubowski and Dr. Turchi present on this timely and important topic for primary care clinicians.
Thank you, Eileen, for that introduction. And I would just like to say what a pleasure it is to be able to present today with my mentor and colleague, Dan Dubofsky, who really is the person who first introduced me to what fetal alcohol spectrum disorders is and the difference and the nuance between how I was trained 20 years ago on fetal alcohol syndrome. So we are thrilled to be here today with our third webinar. As many of you know, we've had a series. And we're talking today, we're moving along that continuum, and we're going to talk about treatment across the lifespan with persons and youth and children with fetal alcohol spectrum disorders. Before I get started, I want to give a little bit of background about the presentation. As many of you know, many of you have participated in our previous two webinars, and this is all part of a project from National American Academy of Pediatrics. There is a project there on fetal alcohol spectrum disorders prevention and practice through a national partnership collaborative that's funded by the Centers for Disease Control. And part of their aim in doing this project and us bringing these webinars is to help pediatric care providers become more aware of and know more about fetal alcohol spectrum disorders so that we can be better in our practices at identifying, referring, treating, and managing children who may have been prenatally exposed to alcohol. So this is our third of the series, and for those of you that may have missed some of the others, they will be up on our website for Medical Home. And at the National AAP, Drs. Wozgarski, Centurion, Smith, and Shaw helped with the development of some of these slides. So the objectives for today, we have four objectives, Dan and I. The first is to describe and identify potential referrals, secondary conditions, risk factors, and care planning for individuals with fetal alcohol spectrum disorders. And then we'd like to talk about developmental and functional concerns for those with FASD and their families, talk a little bit about various treatment approaches, and talk about some of the secondary conditions and support services and resources for families and providers. So I think that, to get started, I think it's important, and I feel as though someone who's very interested in FASD, that I always like to highlight why prenatal alcohol exposure is, relevant to our work in pediatric practice. It's so important, and I think especially in light of, what we're all seeing with the opioid epidemic. I see it all the time when I see babies that, we're very focused, of course, as we should be, on NAS and infants who are substance exposed, who may, have get treated with morphine and are in withdrawal. And so often alcohol is in partnership with that and at times overlooked, especially because it's not routinely tested for and doesn't show up on, the NICU discharges or newborn reports that we get with urine drug screens. But it happens a lot. And we also know that alcohol is a developmental brain injury, and it's very preventable. It is, one of the very top common causes of intellectual disability and behavior problems in pediatrics. So it's very interesting, and I think I, definitely have learned this from Dan years ago, that people are often surprised that the effects of alcohol can be greater than those of recreational drugs and teratogens. And it's important to remember that behind tobacco, it's the most common substance to be used with other drugs, whether that's illicit or, the abusive opioid. And I, will even say that, I think that the pendulum has swung. I know now for me in my own practice, when I talk to moms about substance exposure, as you can imagine, I'm pretty compulsive about asking about alcohol at multiple visits. I find even now marijuana, when you ask about, I have to ask about it separately because most young adults now don't really consider marijuana to be a drug. I find that I actually have to ask, I ask separately for heroin, marijuana, alcohol, because it's just sort of how so many things have become conflated, and that alcohol is even more common than all of those things that many of us are seeing. So it's also, this topic is important and relevant to us in practice because so many of the things that we see in pediatric practice can be attributed to, at least in part, by potential alcohol exposure. So thinking about when we are taking care of children in practice, some of the growth issues that we have. So, not to say, we know that the most common cause of failure to thrive is not an underlying medical problem per se, that a lot of it can potentially be social, but certainly we know that children that have full-blown FAS are going to have growth issues. And certainly because of some other behavioral issues, it can affect growth. So it can be part of the problem, especially in the child already at risk. at home for a variety of social, emotional, or behavioral issues. Also, we know that things that we see in our practice related to dysmorphic facial features can be attributed to at times fetal alcohol syndrome or spectrum disorder. And also, the big thing that a lot of us see are the structural and functional brain malformations that may manifest as developmental delay or behavioral issues. We all see that a lot in practice. I'm sort of thinking about, any of those that might have major and minor effects long term. And so while the combination and severity of the effects can widely vary across patients we see, it's really that functional deficit and behavioral issues that are resulting from that prenatal damage from the alcohol that can bring a child, to our attention in our office, and why it's so important that as medical homes we're thinking about this and it's on our radar. And the other thing to really remember is that this is permanent and lifelong. So these effects don't go away. There's no cure. I mean, there certainly, are ways that we can certainly with things like early intervention, the thing that Dan and I are going to talk about today, there's things you can do like we do for many children with autism and other behavioral issues. But it's really important, especially as a medical home, that we are often the constant in these children and then youth lives, that we really are thinking about, the FASD and having it on our radar so that we can best provide care to these children and their families in their medical home.
Okay, thanks, Renee. And I want to also welcome you and thank Medical Home, and certainly thank Renee for having me involved in this. And one of the things that's so important to keep in mind, especially for pediatricians, is that because of what Renee just said, that this is lifelong, is that not only is it important to recognize the potential for the effects of prenatal alcohol exposure in the children and youth with whom you work, but also in the family members, because we also see adults. So it's kind of those families where they don't show up for their appointments on time. They call in the office repeatedly for the same thing, that it may be that they may be affected as well. So what we're going to talk about in terms of, and what we've talked about in the other webinars about what we see behaviorally and why it's important to keep in mind for the adults as well as the children. So as Renee said, this is a brain-based disorder. And the experts in brain research and FASD have said that the behaviors we typically see in FASD are due to the damage in the brain. And they're not willful and purposeful behaviors, and therefore the approach to those behaviors that you can educate families on needs to be different than it would be for others. Some of this is just a slide with some of the areas of the brain that are affected by prenatal exposure. The frontal lobes have a lot of very important functions, including abstract thinking, and what we see across the IQ span. And we see IQ from a low of about 29 or so to a high of over 140 with an FASD. So it's a wide range. Not everybody with an FASD has an IQ under 70. Actually, the majority have an IQ over 70, which means that they don't qualify for a lot of services. But no matter how bright they are, they tend to be very, very literal in their thinking. So we have to be careful how we say things to them. The frontal lobes are also responsible for things like deciding what to do in a specific situation, kind of those executive functioning pieces. So the ability to take what's been learned in one situation and apply it to another situation is very difficult for most with an FASD. The frontal lobes are also responsible for processing humor, and one of the things that gets them into difficulty sometimes is that if somebody is joking around with them, they'll laugh along with the other person, but not understand it's a joke and maybe think the person is angry at them or hates them. And that's what they respond to, because they can laugh, but they can't figure out what's going on. The corpus callosum is another structure. It's a bundle of fibers that connects the two halves of the brain and allows the two halves to communicate with each other. and in FASD it's often thinner than it should be, especially in the back, smaller than it should be, and sometimes it's non-existent, which means it's very difficult for information to get across the two halves of the brain. However, there has been research with children under the age of 7 that has shown that giving them bimanual exercises to do has increased the thickness of the corpus callosum. So we can really change brain structure by providing those kinds of bimanual exercises that forces the two halves of the brain to communicate with each other by building those nerve networks across the two hemispheres of the brain. The basal ganglia of the brain is really important. It has, as you see here, it has a lot of functions. Particularly, it's connected with motor activity, fine and gross motor coordination, balance, and those are issues that a lot of these kids and adolescents have. The balance problems go into adolescence typically. The fine and gross motor coordinations we see early, coordination problems we often see early on, which means that a referral for early intervention for those infants and toddlers 0 to 3 is really very important, and physical therapy for those, and occupational therapy for those who have those difficulties. There's another structure in the basal ganglia called the caudate nucleus, and some recent research is showing that even when the overall brain size is smaller than it should be due to the effects of prenatal alcohol, the caudate nucleus is even smaller than it should be for that brain size, which means that that's a structure exquisitely targeted by alcohol. And the caudate nucleus, as we understand it now, has every structure has a number of functions, but some of their functions are cognitive abilities, cognition, and emotion and the expression of emotion. And the hippocampus is also involved in emotion and the expression of emotion, and is also affected by prenatal alcohol. So what we see in some of these individuals with an FASD is that they may laugh when somebody gets hurt. They may smile or laugh when somebody is talking seriously with them about what they've done wrong. And it appears then that they have no conscience and no remorse. But at times what it is a disconnect between what they are feeling and how that feeling is expressed facially and verbally. That may well be due to damage in the caudate nucleus and the hippocampus. And the problem is people don't respond to what people are feeling, they respond to what they see. So if they see somebody laughing or smiling when somebody gets hurt or they hurt somebody, then they think they have no conscience or no remorse, and they consequence them for it. That's not going to be effective in these cases. The hippocampus, as I say, is also responsible for memory, and especially the area in the dorsolateral prefrontal cortex of the brain, which is responsible for working or immediate memory. And because that's impaired, what happens is that somebody will tell a child to do something, give them 2 or 3 instructions, they won't do them, they will look like they are being oppositional, and they may get a diagnosis of oppositional defiant disorder. But with damage in working memory, so if you say to a child, if a parent says to a child, go upstairs, brush your teeth, get in your pajamas, get ready for bed, and they expect them to do that, they go up a half hour later, they're playing, they haven't brushed their teeth, they haven't gotten in their pajamas, they're not in bed. Looks like oppositional behavior, but what happens in these cases because of damage in working memory is by the time they get upstairs, they have no idea what they were supposed to do next. So teaching families to do the kind of one direction, one step at a time, the same thing in school, the same thing in any setting, one direction, one rule at a time, with lots and lots and lots of repetition, understanding the damage in the hippocampus, in the dorsolateral prefrontal cortex of the brain. Actually, the dorsolateral prefrontal cortex, that's the area responsible for working memory. The other one I want to touch on is the amygdala, where the roles of the amygdala that are really important in understanding for children and adolescents and adults actually, is that it has a major role in recognizing danger and fear and knowing what to do, fight or flight. And that's damaged by prenatal alcohol. So these kids often have no stranger anxiety. Adolescents and adults don't recognize dangerous people in dangerous situation. That puts them at high risk of abuse and trauma. And the other thing to be aware of is that there are other issues that they have, like poor sucking reflex, failure to thrive. They're seen as picky eaters. They don't eat well. They don't sleep well. Some of them are up all night. They are at very high risk for abuse and trauma because they're very difficult kids to raise, even when parents have no issues of their own. And that's just something to be aware of as a pediatrician and to pick up. Let's see. Oh, there we go. So in terms of the terminology, the term fetal alcohol spectrum disorders is an umbrella descriptive term, not a diagnostic term in the U.S. It was created about 20 years ago to really convey the sense that this is a true spectrum. So not everybody with an FASD has the same issues to the same degree. It's a spectrum from very mild to very severe. And one of the things, is, again, as pediatricians to be aware of is that one of the results of prenatal alcohol exposure is fetal death, and also miscarriage in the second trimester of pregnancy with alcohol use. So if you're seeing a family where there have been, one or two or more miscarriages, it's essential to start talking and asking about alcohol use during pregnancy in a way that really is totally non-judgmental, because that's really important. So under the umbrella of FASD, there are a number of diagnostic terms that are being used. Fetal alcohol syndrome is the full syndrome with certain facial features, central nervous system abnormalities, growth, height and or weight below the 10th percentile sometime in the first year of life, and either confirmed or unknown maternal alcohol exposure. It's the only diagnosis we can give with unknown maternal alcohol exposure at this point. The terms partial FAS or PFAS, alcohol-related neurodevelopmental disorder, and hold on a sec, sorry. Oops. Alcohol-related neurodevelopmental disorder, alcohol-related birth defects those are terms that were coined in 1996 by the Institute of Medicine. So partial FAS are those who typically have the facial features, the central nervous system dysfunction, but typically not the growth deficits that we need for a diagnosis of full FAS. Alcohol-related neurodevelopmental disorder are those who have the cognitive deficits without the facial features that we see in FAS. And alcohol-related birth defects are those who have the congenital anomalies without the rest of the difficulties. So it's rare to only see the congenital abnormalities. However, it's so important for pediatricians to look at some of those physical deficits and physical illnesses that we're beginning to see much more common in FASD. So, for example, any child who has been born with a seizure disorder, any child with cleft lip or palate, any child with scoliosis, with certain atrial and ventral heart abnormalities, we should be asking about prenatal exposure to alcohol, because it's one of the causes, not the only one, but it is one of the causes. So there are 3 young people with FASD who have been doing a survey of adolescents and adults with FASD around the world in terms of some of their physical illnesses, and finding striking degrees of things like diabetes and other physical illnesses. And some researchers are working with them now to look at, could that be caused by the prenatal exposure, by living with this, or what's going on? The term neurobehavioral disorder associated with prenatal alcohol exposure, which is called NDPAE, is in the DSM-5 Diagnostic and Statistical Manual of Mental Disorders. However, and it's in section 3, which is the section of syndromes for further study. It doesn't have a diagnostic code with it. However, in the body of the DSM-5, there is a term called neurobehavioral disorder associated with prenatal exposure. It's under other specified neurodevelopmental disorders. And that has a billable code a DSM-5 code and an ICD-10-CM code. So that's really a term that we can begin to use. And then under that, we can talk about where is it, is it ARND, is it partial FAS, where is it under that umbrella, under that term of other specified neurodevelopmental disorder, which is 315.8 in the DSM-5 and F88 is the corollary in the ICD-10-CM. Renee?
Thanks, Dan. 1 second, I might have gone.
Yeah, you went there.
Sorry, get the slide. So, while we know that when we see children and youth with FASD, just like many other diagnoses like autism, if you've seen a child with an FASD, you've seen a child with an FASD. There are not really many that I've seen that are completely alike, but they definitely have some common features, and that's really what we want to sort of talk a little bit about today in terms of making sure you kind of have some things in your mind. So some of the normal behavioral characteristics and impairment to think about with neurocognition. As Dan mentioned, you can have a reduced IQ, but that's not necessarily totally common. Certainly we see a lot in the way of learning and executive functioning impairment. In my fetal alcohol program, we have a neuropsychologist, and I always learn so much when I work with our mental health professionals. And you just hear families talk a lot about, even some children while they're getting some learning support, often some of the biggest challenges are in, just sort of keeping that planner, being at home and following directions, and often knowing appropriate social norms. So those that executive functioning can be really challenging and often really difficult for teachers and parents, and understanding the science behind it and sort of how to address it is really critical. And so while Dan mentioned earlier that many individuals and children with prenatal alcohol exposure do not necessarily score in the range of intellectual disability, they typically more score in the low, average, or borderline range with very specific things. And we have had even a couple of children in our fetal alcohol program that have scored lower. Some of them also have other, sometimes they'll have children who have comorbid other diagnoses and things like autism or other diagnoses. But in general, kind of keep that into your head. There is a degree of impaired self-regulation. So as Dan had mentioned, the mood, the attention and impulsivity, and so you couple that with the executive functioning. I mean, that's why there's often a lot of risk-taking behavior, especially in thinking about teens. So we worry a lot, about, excuse me, some of the the large number of children that, I'm so sorry, can be at risk for going to juvenile detention centers and being incarcerated for risk-taking skills. So there also are delays and impaired adaptive skills. So those would be things that are the daily living skills, allow a child to function at home, at school. So thinking about, those communicating and those social skills. So, you think about as kids are starting school and they're kind of, putting together their little tribe of friends, and you have a child who has fetal alcohol who doesn't understand those norms, or maybe can't run as well as the other children, or has this impulsive behavior, constantly getting into trouble. Or as I had a little patient, and my daughter had this too in her class. They have these, some schools will do things like, in terms of trying to be, you might have a teacher who has all the kids. I had this example where they all have their frogs on the board with their names on them, and like your frog, and they were all in a little pond. And when you misbehave, your frog was out of the pond. It got kicked out of the pond, which was like, and just like to hear a little guy talk about how his frog is never in the pond, and it's just this poor little person who just can't keep his frog in the pond because he is, just has such challenging social skills. And if you have a teacher who's not understanding that this child isn't following directions like the rest of the 5 or 6-year-olds, he can only do one-step commands and needs to get his pencil out before you start telling him that, it's time to turn to page 10, he appears defiant, and his frog gets kicked out of the pond. And then he goes home and his self-esteem just becomes cyclical. And then the other children perceive, Johnny as never being in the pond, and he's, not someone that they necessarily want to play with, or he's in trouble a lot. So it has sort of these downstream effects if you sort of think about why the response to some of these neurobehavioral characteristics are so important. And the same sort of goes for at home as well. A child could remain in trouble all the time, and I feel like we talk about this a lot with parents, and it's often difficult when parents have more than one child. Especially, let's say, I see a lot where sometimes maybe one child's adopted, and the adopted child, may have been alcohol exposed, and so sometimes it's just hard, to feel like as a parent there's different rules that, Johnny may get extra direction time or extra time to get ready, but, nothing can send a child with FASD into a more of a tizzy if you're getting ready in the morning and you're saying, get up, brush your teeth, put your clothes on, come downstairs, don't forget your book bag. And they might come down like half-dressed with no hair combed, no brush, no brushed teeth, and no book bag, and before you know it, they're grounded, and this just escalates, and then, their whole day just starts off wrong. So sort of training families to function so that everybody's day sort of starts off okay, and using things like, we use a lot of like PEX boards and things to help families cope, and also do a lot of training with families to have realistic expectations as well as sibling expectations. Really helps the overall dynamics. The other thing is the physical characteristics. So we talked about this a little bit. I mean, growth problems, certainly failure to thrive at any stage during development. We look at that. Sometimes we'll see children, they'll come to us for a consult, and maybe at age 6 or 7, they're hitting their growth chart fine, but my team knows that I'm really obsessed with, I want growth charts from wherever they are, even if it's Kazakhstan, and I look at the kids' growth all along, because truthfully, some of these kids often have problems with growth early on, and they might catch up. So looking at a cross-sectional view at one point in time doesn't always help you. And so just also always remembering when we did some of this, you can see children with fetal alcohol, they certainly have the classic thin upper lip and smooth philtrum. They certainly can have, their palpebral fissures, their ears. They can certainly have sometimes midline defects with their faces. They certainly can have small heads and microcephaly. So, sometimes you're not going to see the classic fetal alcohol syndrome signs, but I'm always kind of measuring things and just really intrigued by, a child's physical and facial characteristics. So it's important. What we wanted to shift into is just sort of thinking about this across the lifespan. So we're going to consider how to address these characteristics from the age of 0 to 3 to preschool age, and then thinking about adolescents and teens. So as we think about children in birth to 3, which is when many of us as pediatricians are often seeing these kids, we know that in infancy the most active areas of the brain development involve that myelination. Dan did a great job. And that myelination of the sensory motor pathways is what helps mature, that's where the limbic system is maturing. So the neurobehavioral deficits that I just talked about, and we're going to delve into deeply here for 0 to 3, include those deficits in motor function as well as emotional and state regulation. So we often don't see the language delays as much in this period, but there may be more receptive language, like the 2-year-olds, as they're transitioning into where they should be following commands. They might not be able to follow instructions. We certainly see some low tone. You often get the report, if you have a biologic mom, that these children were a little bit irritable, cranky, not good breastfeeders. I just saw a little girl whose mom said that she pumped the entire time and just fed her bottle. She could never get her to latch. They often look a little like an NAS baby, so they're easily startled, they seem irritable, they have disordered self-regulation, so they often don't sleep well, so you can see where this leads to like lack of attachment. Some of the kids that we see in our program are actually sometimes they come to us from Eastern Europe, from some of the orphanages where, they have reactive attachment just from that. But even for children who have been with biologic or foster parents early on, they often are described as difficult to soothe. They do need close monitoring, so early intervention is like a must. I say don't pass go. You meet, in Philadelphia at least, I'm sure it's similar in other areas, just by any substance exposure, you automatically qualify for early intervention services. So don't ever hesitate to send them there. Thinking about the physical concerns, definitely worry about poor immune function. These are kids that might have multiple ear infections and URIs and viruses. I already mentioned they could have poor weight gain, so it might be their velocity. They could have failure to thrive, not eating well. So, kind of thinking about, these issues, you're really kind of hitting things. Also, always remember that some kids have comorbid conditions, so you always want to be looking up, if they have a comorbid syndrome with their fetal alcohol or other things, that you're looking at both of those things together. You always want to make sure that as you are when you're referring to early intervention for those neurobehavioral concerns, that sometimes you'll find your early intervention providers aren't as familiar with fetal alcohol, so you want to make sure you talk to them about targeting gross and fine motor skills and those language skills. But also that, I find it's challenging in early intervention. They often aren't doing a lot of behavioral interventions. It's not usually until I have kids that have autism where they potentially can get ABA at home. But sometimes if you have a good therapist or someone that you can help work with families, you want to sort of help them understand what fetal alcohol looks like and help them understand the self-regulation, the adaptive skills, that these are sometimes challenging, and that, really when you think about early intervention, we know that it's set up so that parents are supposed to kind of learn the therapies and then watch the physical therapist or occupational therapist do it and then repeat it. But if the parent or the therapist doesn't really understand that a child with fetal alcohol needs to be taught a little bit differently, they're going to get very frustrated. So it's important to sort of think about that in terms of how you stimulate and overwhelm and not take out 25 toys, doing one thing at a time, really looking at how to address their services in a way that meets their needs. So remember, I know that I think all of our, in Pennsylvania, FASD is an eligibility for early intervention. If you're practicing outside the state, you definitely want to look up what your criteria are. But just remember that, thinking about all the things that sort of play into this is important. And even if you see a baby or an infant or a child who was exposed and maybe is meeting their milestones, still refer them, because what they'll do is they'll put them into something called EI surveillance. Which means that they'll get periodic calls from the system just to check in on the family, check in on the milestones, and especially if that child is lost to follow up in your practice, they're on the radar of someone to just be following their development. And I have found that when I have kids that stay in surveillance, if a year from then I tend to have a concern, it's a lot easier to get them looped in and just increase the OT services than from starting from scratch where I have to re-refer. So keep EI in your bailiwick and use it very liberally, and don't pass go when you have a child with fetal alcohol. So when we think about preschool to school age, they tend to have problems there in their higher order cognitive functions. So those are, when you start thinking about this is intellectual functioning, so if they have any issues with their IQ, this is where you're going to start seeing it. The learning issues, often we see deficits in math, so the operational skills, that application, that integration, reading and comprehension, and the visual spatial issues. I see our neuropsychologist a lot, she'll often talk about that. And also remembering that because these kids, I see it so often, I almost feel like there's probably not a kid in my fetal alcohol program that's not at least on melatonin, if not something else. So sleep issues are a big deal for families. And you think about for any of us, or even typically developing children, right, you have a bad night's sleep, you just have like a bad day at work, you're not at the top of your game, maybe you're more irritable, you're not able to get stuff done as quickly. So you couple that with someone who doesn't have the same coping skills as many of us do, and you have these kids that have poor sleep hygiene, and I often have to talk a lot to parents. Any child shouldn't have devices in the room and things like that, but for a child with an FASD, it really sets them up for just worse behavior, worse functioning. So important to think about that. I talked a little bit about the executive functioning problems, but thinking about that memory and the sequencing, organizing tasks. So when you start hitting school age where you're expected, to write down your homework or bring in your gym clothes, that really proves to be a problem for these little guys. They often have problems encoding and consolidating new information. So you see that a lot with our testing. Our neuropsychologists will do a lot with memory, giving folks 3 words, numbers, asking them to encode and remember, and they have a really hard time with that. Higher order language processing, so, metaphors or making abstract thinking, kind of doing the analogies are very hard for them. Handwriting is often really messy. Now that I think handwriting is becoming less of an emphasis in school, where kids aren't even learning cursive anymore, it still is important. Certainly math calculations, especially as you start getting into geometry and algebra, it's harder for them. They really struggle in school. You hear a lot that, moving to a new school, a new environment, changing a classroom. If a child, I've had parents tell me this, where like, they're having a great morning, I don't know what happened, and then they come to find out in the child's notebook that like they got to school, someone was also in the class, they had to go up one floor to a different classroom, and for most kids that's just going up there, but for this child with FASD, it just sent them into a tailspin and they were in trouble the entire day. So, and it's also really hard for them. They're not a kid that you're going to give a map to and just say, go find your way. These children also have problems interacting with others. They often come off as being immature. They, sometimes have difficulty like with the playground rules and learning. So, they might, be on the playground one day and Susie doesn't like to be spun really fast on the merry-go-round, and then the next day they do the same thing and the same thing. So where Susie's like, what the heck? Doesn't he know I don't like the merry-go-round? And he's flipping me around. She gets angry. She starts to hate this kid. He just honestly doesn't remember. They often can be perceived as overly social and, can come off as being intrusive. So it's important to just remember these things as you work with teachers and with families, and know that some of their issues can be related to and appear to be having issues with like ADHD as well and attention. So in thinking about the medical and psychological concerns, you definitely also want to think about family-based therapies, and sometimes just to help with the behavioral issues and the family dynamics, especially when there's siblings. This causes a lot of stress on marriages. Families will talk about how it's just like the thought of even going to like Applebee's for dinner is just horrible, so they just stay home. But it's important to think about the social skills training, not just for the child in school, but for the family at large. I talked about addressing the sleep, and you always want to make sure you're treating or referring for things like the ADHD or depression or oppositional defiant. If they have other comorbid conditions, even if it's something that you're not comfortable treating, you want to refer out. And I think it's just so important, before I turn it back over to Dan, to just remember the anticipatory guidance. I mean, I find a lot when we do our feedback with families after our multiple testing, we have very concrete suggestions about what we found, but so much is about, really the anticipatory guidance and helping them with some of the behavioral so that they can function at work, function at school. We had a youth once that was like, it was worked at Sesame Place here, and it was like the perfect job, had been through a bunch of different jobs, but Sesame Place was great because it was very regimented, and, and the people there knew that, like, the 3 rides that he was in charge of, like, never to change that, and even if the ride was shut down, he just didn't deviate. He wasn't someone that could go over to the teacups. And so that really came from his mom being such an advocate for him. And so that's the kind of stuff you want to help families do and support, because that is what helps some of these youth become the ability to be independent. And to me, that just fosters self-esteem and allows them maybe to have healthier relationships and things like that in their lifetime. So Dan, back over to you for adolescence.
Okay. So in adolescence, really a lot of the issues that they have are continued from what Renee just talked about. And again, the difficulty eating sometimes goes right into adolescence, and they're seen as just picky eaters, but it really is a sensory issue. It really is the temperatures, textures, and tastes of foods. So helping families understand that picky eating is not just willful behavior, that a lot of these are not willful behavior. And again, the same things with executive functioning difficulties and the difficulties in working memory, and especially the difficulties in things like, as Renee talked about, verbal receptive language processing. And as they get into adolescence and they're in middle school and high school, most education is based on auditory learning. My son, for example, when he got into middle school, he came home from school and he said, "Dad, when I walk into school every day, I feel stupid." And not many of us would put ourselves in those situations over and over again, because they have difficulty following what's going on in school, getting to the right class at the right time with the right books or the right papers. It's overwhelming for them, and it's almost intolerable for many who feel that way, and then they end up either truanting or getting thrown out of school. And helping understand why they're doing this is really important, not just consequencing them for truanting or for getting thrown out of school, but trying to figure out why this is happening, and understanding that a lot of it for many of them has to do with how overwhelming middle and high school are for them. because the expectations are so high, and especially those who are bright, an average IQ or above average IQ, who are verbal, who have an FASD. They're the ones who tend to do worst because people don't look at them and recognize they have a disability. So all of those, the difficulties in school, especially in math, the difficulties with peers in social situations because they are very, very naive and gullible. They really want to be liked. They want to be helpful. They are often rejected by their pro-social peers because they are a little bit overly friendly, intrusive, and so they're rejected by their pro-social peers. They gravitate to the negative peers, the gangs, who see the neon sign on their forehead that says sucker and can manipulate them. We really need to help the family identify what their strengths are, what they do well, and get them, connected with more positive role models. And many of them feel more comfortable with younger kids. There's a risk of substance use for a number of reasons. We know, for example, that there is a genetic vulnerability for substance use. We know about family histories of substance use where it's just part of the family tradition. Peer pressure may come into play in terms of substance use. And also, if we look at the epigenetics, there's some early research that's showing that with alcohol exposure from use from the parents or grandparents, the offspring may have the gene for a bitter taste alcohol turned off, which may put them at higher risk. And the other reason for substance use is because if you are in a situation where there's so much emotional pain because people are telling you you can do it, you're just not trying hard enough, and get consequence for it and not understand why you keep getting consequenced, one of the ways to deal with that emotional pain is to use substances. It's not a great treatment, but we understand why that happens, why there are a number of adolescents and adults with an FASD who end up with substance use issues, and our typical treatment for those don't work if we don't recognize the FASD. The risk of injury, because of the poor decision-making skills, but also because of the damage in working memory and the inability to recognize dangerous people in dangerous situations. So we can't use natural consequences of you get in that situation, you experience a consequence, then you will learn not to put yourself in that situation again. It doesn't work, just puts them at risk. And then the possibility of co-occurring mental health issues, but also recognizing that some of the behaviors that look like things like ADHD or bipolar disorder or oppositional defiant disorder or conduct disorder may well not be those disorders. So it's really important to figure out what's really going on in terms of what the approach should be. This inappropriate or risky sexual behaviors, I think one of the things we don't talk enough about with families and with early adolescents with an FASD is the risk for sexually transmitted infections, early pregnancy, HIV and AIDS, because of the difficulty in recognizing dangerous people in dangerous situations and knowing how to negotiate those situations. And the only way to do it is by lots and lots of demonstration, role-playing. Individuals with an FASD tend to learn best by modeling the behavior of those around them, not by being told what to do, shown what to do, or consequence for not doing it. So we need to do that repeated modeling, and it always has to be repeated because of the damage in working memory that we talked about earlier. So again, it's, getting schools to understand that they need to modify the approach for adolescents as well as younger kids with one direction, one step at a time, maybe setting up buddies to get from class to class as a support. Neuropsychological testing is very, very useful in identifying what their learning styles are, what the things are to avoid. For my son, when he had neuropsych testing, one of the key things that the neuropsychologist came up with was he should never be asked to do expository writing, to like write a story or write in a journal. He could dictate something, but he couldn't write it. That's important for families and for teachers to understand, because when they get into middle and high school, there's all this writing, And these kids have tremendous difficulty with that, not only because of the fine motor coordination and the handwriting problems, but just the thinking and processing issues. Many of them would do well with an IEP because at least if they have an IEP, then the school cannot suspend them for more than 10 days over a year, even though schools try. If they don't have an IEP, schools can keep on suspending these kids. So it's often better to at least have an IEP, an individualized education plan for them. Really looking at, as they move into adulthood, what are the issues? What's going to help them stay safe? What kind of setting would help with them? What kind of supports would help with them? Money is a huge issue as they get older in terms of, can they manage their money, or do they need somebody else to manage their money so their basic needs are met? Somebody will have to sit with them and do the applications and for supported living or housing. And as Renee said, finding the right kind of job for them. They can be really good workers if we get the right kind of job and help employers understand what they need to do in order to be successful with them and to have them be very successful employees. And, deciding, and some families as they get older and adolescents need to decide about issues either representative payee or guardianship, and also issues in things like setting up trusteeship, and setting up a trust for things like life insurance in case something happens to the parents, because you never want to have these kids get a whole lot of money because it'll be gone in a couple of days. Again, we want to not only monitor the psychiatric co-occurring disorders, but identify, are they accurate co-occurring disorders? If it's not an accurate co-occurring ADHD, then stimulants tend often not to work and also may make things worse. But they often have a lot of anxiety, depression, substance use, and how it's monitored. We need to always take into account that they also have an FASD, because that tells us the brain is processing information differently. And Renee talked about the sleep. Exercise is really helpful. The diet is really helpful. And again, identifying something in the community that they can do that's a positive and based on what they like to do, what their strengths are. And very important for pediatricians, you may be the only ones to talk about what are these child's strengths, what do they like to do, and tap into that, and never have the family set that up as a reward for good behavior and take it away for bad behavior, because that'll just set these kids and adolescents up to fail. And you may be the key people to be able to do that. Renee?
Great, thanks. So it's really important to think about, why pediatricians don't routinely screen for an FASD. And part of it is the stigma. Being fearful of the stigma is not the answer. The stigma really starts with us. So it's important to avoid that stigma and keep in mind that mothers are not like drinking in pregnancy to say, wow, I really want to harm my child's brain. It's important to take that history of alcohol exposure for all your patients, normalize the conversation, ask how much did you drink. Many women drink before they know they're pregnant. Did that include something that may have happened to you? Many parents feel relieved when they actually have an answer for a diagnosis that's been plaguing them. I often say kids come to me sometimes with like the onion. They have like 10 different diagnoses, and parents, nothing really explains it. So it's important to recognize the diagnosis is actually more a tool because it allows us to have the conversation. It often can be a segue to services and interventions and resources, and really helps parents understand why a diagnosis for anything is early, and just really helps, it's early and important and helps, maybe prevent another FASD or just helps the child get needed services and support.
So again, as Renee just said, you may be the key person who can sit and talk with this parent or this caregiver about and find out about the possibility of prenatal exposure, and how it's done is so important. And it doesn't take a lot of time, and it doesn't take a tremendous amount of energy. It just takes a lot of caring and being sure that you are non-judgmental and get across the support. is really important. So really talk with them, ask them, and as Renee said, I would not ask any woman if she drank during her pregnancy, but I may ask things like, I explain things like, lots of us celebrate things in our lives. We celebrate holidays, anniversaries, birthdays, vacations. And many of us, when we celebrate, we have a few drinks because that's part of our society. So if you can think back to the 3 or 4 months before you became pregnant, what were you celebrating? Because really that's early pregnancy for most. And being able to get the information about prenatal alcohol exposure is so important to be able to document that, because then as this child gets older, that will be key on getting the diagnosis. If we have documented maternal alcohol prenatal exposure, that's going to be essential in getting the diagnosis of anywhere in the spectrum other than full FAS. And sometimes that information just gets lost because a lot of pediatricians won't ask women about their alcohol use. And again, as Renee said, that should be asked routinely, as she does with, every appointment with everybody, not specific people. You don't pick out, who you're going to ask about their use. You ask everybody, because it should be just routine, but in a way that really promotes honesty, is really very, very important. And just share the facts. If it's a woman of childbearing age also, whether they have a child with an FASD or not, it would be really helpful as a pediatrician to talk with them about the facts of the effects of alcohol, long before most women know that they're pregnant. So it's not a matter of willful, purposeful behavior. This often occurs way before women recognize that they're pregnant. And the effects of alcohol really can start very early on in pregnancy, and continue all the way through pregnancy. So also at any point during pregnancy, it's important to stop drinking, as well as important to not drink at all. It can be beneficial. And recognize that many women are really afraid to talk about it because of judgment and blame and shame and guilt. And also other family members are often very protective and may deny it. So if you're talking with grandparents, they may deny it, or others. So just to open up the discussion and then revisit the discussion. And the last one is really try to use person-first language to avoid talking about the FAS kid. And having been trained in psychiatry, we always talked about the schizophrenics and the oppositional kids, and the bipolars, and that's not using person-first language. And the key in why we want to use person-first language is, and we want to teach families to use person-first language and not talk about their FAS kid, is that language influences our attitudes and our beliefs and our behaviors. And nobody is FAS, but somebody may have FAS and may have strengths and abilities that we want to tap into. Renee?
Great. Yep. So just some things to reiterate. Oops, my fingers are a little quick. That we want, when you're providing care to a child on FASD, as we've talked about, there's medical, there's mental health, behavioral issues, but you always want to remember that the basic anticipatory guidance, keeping the nutrition, the exercise, is important to remember that, thinking about anticipatory guidance, and just, keeping all that in mind too, because they are children as well. The AAP has an FASD toolkit that I think we've promoted before for healthcare professionals. It has a lot of scripts that you can use to talk about, like what Dan did with asking about, whether, how you want to ask and screen for alcohol. But keep in mind, things like the risk of injury for these children, thinking about what we talked about earlier, the referrals to early intervention, because those are all very, very important.
And in terms of pharmaceutical considerations, again, it's really there is no medication to treat FASD, and it really is important to figure out, for example, is this really ADHD, or is it attention problems or impulsivity that are due to something else, and maybe the prenatal exposure in terms of what's done around that. The same thing in terms of depression and anxiety, and especially those of you who may be prescribing psychiatric medications, that especially around depression, that sometimes if you give an adolescent a mood an antidepressant because you think that he or she has a depression, but they really have an underlying bipolar process, about 100% of the time they will develop a hypomania. So it's really important, is this part of a bipolar process or is it a unipolar depression before prescribing any medication? And especially around depression, it's very important if you are prescribing antidepressant medications to monitor the adolescent very, very carefully because of the risk of suicide increases. Often we think because the first thing that helps with antidepressants is improving energy. So you have an adolescent who really was very depressed, thinking about suicide, didn't have the energy to carry that out. Now they have an antidepressant, it improves their energy, they carry it out. I really personally believe that that's where that high risk of suicide comes in with antidepressants. So they need to be monitored very carefully, not here's a prescription with an appointment in a month. The other thing is there are a number of supplements that really seem to be promising. Choline, we see deficits in choline in individuals with an FASD and also in women who have been drinking during pregnancy. We also see deficits in iron and in zinc. So it may be useful as a pediatrician to order choline, zinc, and iron levels for these kids. And if there are deficits, talk about supplements to bring them up to normal levels, not above normal, but normal levels. Because the deficits in choline can translate into cognitive impairments. And bringing the choline levels up to normal may help. And there are some clinical trials going on around that. And the same is true with zinc and iron. The deficits in zinc and iron may translate into some of these kinds of difficulties. Bringing them up to normal levels may improve their functioning. Bringing them above normal levels can cause worse behaviors. So it's not mega doses, but just evaluating, are there deficits in choline, zinc, and iron could be very, very helpful. As a pediatrician, you're the one who could do that. And then again, building the knowledge and skills for parents and helping parents understand that these behaviors that we're seeing, like not following through with what they're told, like being a very slow eater or a very fast eater. And the other thing that we didn't really talk about is that there also seems to be either an overreaction to or an over response or under response to pain. And it could be both, where they may complain about bleeding profusely and they have a little scratch, but at the same time they can walk around with broken bones for days and not even recognize it. And we see that kind of a lot in FASD. So being aware of those things and helping parents be aware that, oh yeah, we need to break things down to one step, one direction at a time, model for them. And also the other thing I think to help parents understand and parents do is start telling their children with an FASD what they're doing right and what they're doing well. Because so often these kids hear what they're doing wrong, how they're messing up, and get consequence for it, and that doesn't work. But telling them what they're doing right and avoiding that reward and consequence, that starting a sentence with if or when, but rather using a kind of positive focus, which is, gee, you didn't hit your brother in the last half hour. That was great. Thanks so much. That was really good. That was good. I appreciate that. Could be a little tiny thing, but telling them what they're doing right instead of always what they're doing wrong. And if you set up if or when, reward and consequence, then you're relying on their abstract thinking concept of historical time and future time, which is impaired, the idea of cause and effect. So they don't understand why they're being consequenced. They start thinking that they're just bad. And then supporting family members in supporting their children, because again, these are really difficult children and adolescents to parent, and parents and other caregivers need a lot of support in terms of acknowledging what they are doing right as well. And keeping that discussion open, I think, is really important.
Great.
Renee?
Thanks, Dan. So in many cases, it is not quite clear whether all the criteria are met, and referral to someone who has experience with an FASD diagnosis is necessary. It's important because both physical and the behavioral issues that we mentioned need to be considered when you're evaluating them. So often pediatricians have to gather all that information from individual visits that you have and then consider that diagnosis with some of our own findings. But once the diagnosis is made, it's important to consider referrals to determine what else the child needs with respect to therapies, whether you're getting your social worker involved in terms of family functioning, certainly the medical specialists if they need cardiology or ENT, and then certainly, very importantly, are any of the psychologists, behavioral issues, and as I mentioned earlier, early intervention.
And then again, we talked about a lot of it. We talked about the IEP, which again, I think one of the most effective parts of the IEP is the inability of a school to keep suspending these kids because they're difficult to teach as well. But also really important to help parents and other caregivers understand that they have a role in the IEP, and really the IEP should begin by talking about the child's strengths. And the student's strengths and what the goals are, and really for the family to feel comfortable in speaking up, which is difficult when you're sitting in a room with a bunch of school personnel and saying this is what this child needs, and also helping families understand and find out about what is law, what's education law. And Pennsylvania has some great education law centers that can be really helpful in understanding what can the school do and what can the school not do, because the schools will often tell parents, yes, your child needs this, but we can't afford it. That's not our problem. That's the school's problem. If the child needs it, the school has to find a way to do it. So understanding that, because schools are really very intimidating sometimes. And then the 504 plan is really, that's where we will see under other health impaired, that's where we may see the FASD, which again allows for the recognition of the child with a disability. So you see the OHI, other health impaired, we've been trying to get it specifically listed like autism is. We haven't gotten there yet, but still working on that. And looking at what are the issues in school and how they need to be addressed. And again, as a pediatrician, being able to send a letter or develop a letter for the school to support what this child or adolescent needs can be really very, very useful for that. And again, looking, the community programs and everything.
So it's important that any child with an FASD, like any other child with a developmental disability, needs that interprofessional approach. So as a medical home, we're really in charge of kind of leading that effort. So we just included here some resources for you. There are these interprofessional health collaboratives. There's actually this Catalyst Learning Center. We have some of these resources for you. That's interprofessional care for folks with FASDs, and there's educational collaboratives as well. So I just want you to kind of think about that interprofessional care, and it's a lot of what underscores what we do in medical home and what you guys are all doing in terms of coordinating that care, but always remembering that the family and the youth, when appropriate, should be at the epicenter of those teams.
And I know we've gone over, but we wanted to just, quickly touch base on these last few things. That again, youth with an FASD kind of have a likelihood of getting involved in trouble with the law. Not all of them do, but the reasons involved, include that the lack of recognition of dangerous people in dangerous situations, the desire to fit in and to belong. So they'll, the gang will get them, or this group, and say, in order to be our friend, you have to go rob this store. Or because we're friends, I need my son got picked up for shoplifting because he was shoplifting a telephone cord for a friend of his. And he thought he was doing the right thing by helping his friend. So, not the inability to predict the consequences, which is an abstract concept, puts them at risk. Some of them have been physically or sexually abused, and what we know is that when kids have been abused or individuals have been abused as children, that often they will respond physically if somebody grabs them, and that happens sometimes as, a police officer tells them to stops them, tells them to do something. They don't process the information quickly. The police officer grabs them, they haul off and hit the police officer, and then get into serious trouble. Those are some of the reasons that they get into trouble with the law. Often they would be safer in a juvenile facility than an adult one. However, one of the problems is if they're put in a facility with other prisoners who may be truly, clearly delinquent, maybe sociopathic, they could model that behavior. And we want them with more positive people to model that behavior whenever possible. So again, Renee talked about the toolkit, really helpful. Please take a look at it. Has some really very, very important information and can be a great guide for pediatricians.
Great. Just sort of wrapping up here, thanks for those of you who've hung in there. I think just in reviewing, we already talked about the primary facial features for FAS, or short palpebral fissures, a smooth philtrum, and a thin upper lip. Remember that the NDPAE, you need alcohol exposure and the impairments in self-regulation, neurocognition, and adaptive functioning. Always remember that traditional therapies may not work best for children with an FASD, so you need to work with early intervention and parents to help them understand those. And remember that, thinking about regular scheduled follow-ups conducive with and consistent with Bright Futures guidelines are critical. You want to think about getting evaluation with a psychologist or neuropsychologist to evaluate some of the things that Dan and I talked about with neurocognitive functioning and the self-regulation and adaptive functioning. Certainly med management or referral out to psychiatry if you need that, if you're suspecting things like depression, ADHD, oppositional defiance. And also remember, Dan touched on some of the transition issues, thinking about guardianship and power of attorney, and a lot of the underscoring of embracing family-centered care that all of you know. We do have some references here for you to have. They'll be in your slides. And I think we're kind of out of time for questions, but I think it would be, if you want to email questions to Iris or Eileen, Dan and I will be happy to address them. Thank you so much for letting us do this webinar.
This concludes our webinar. I want to thank Dan Davosky and Dr. Turchi for their excellent presentation. I also want to remind everyone to complete the post-evaluation. If you have not received this post-evaluation, please reach out to us and we will be sure to get it to you. Many thanks again to the Pennsylvania Department of Health for the funding that made this webinar possible. Thank you.